Most for calling me over for this presentation. We have been talking about individual tests since morning. We have been talking about CDC. We had a session on CDC. We spoke, Dr. Anil Nandu spoke about flow cross-match. Dr. Ankit also spoke about Luminex-based assays. So my job is to bring all the tests together and put forward an algorithm which we have been practicing at our center, and that was actually based on the study that we did, which is we have been talking since morning, that is the Delhi approach. So I'll be talking about a little bit about Luminex-based test and what these beads can actually do, and then talk about what algorithm we follow, and if it is pertinent to your setting, you can also have that at your center. So what is compatibility testing? It is a set of tests which are performed in the pre-transplant setting to assess the immunological compatibility between the recipient and the donor. And what is an alloimmune response? It is the recipient's immune response which recognizes the donor organ which is put inside as the foreign and mounts an immune response. So we all know what are the early challenges. We have surgical challenges in kidney transplant, 𝘠𝑚𝑦𝑎 reperfusion injury, we have a cellular rejection, and more importantly, what we are worried about nowadays is acute humoral rejection, and which I'll be actually dealing with, and all of us still don't have an answer for. Cellular rejection with the immunosuppressive regimens that are available nowadays, it's still taken care of. But acute humoral rejection, whether it is acute, hyperacute, or chronic rejection, is all that we are worried about, and all these tests are trying to combat that. So what are the tests available for antibody detection? So there are antibody and PRA, which can be qualitative or quantitative, or we can have cross matches, which can be both physical, and we have a virtual cross match. In physical cross matches, we have had a session on CDC cross match, Luminex cross match, flow cross match, and we have the virtual cross match. Of course, there are non-HLA antibodies to detect. So this just a brief about Luminex-based assay. What is a Luminex technology? It is like a glorified flow cytometer. It is a multiplexing technology using a color-coded beads for simultaneous detection of multiple analytes. And the principle is very simple. You add the analyte, that is the sample is added to a mixture of these color-coded beads, and these pre-coated with the analyte-specific capture antibodies, and these antibodies bind to the analyte of interest. You have a capture antibodies which is there on these Luminex beads. You have a target analyte, and then you have a detection antibody which is like a sandwich there. And these detection antibodies are then fluorescently tagged so that you can actually see these are biotinylated, and then they are fluorescently tagged, and you can have a streptavidin or a phycoerythrin which will actually detect it. So the signal detection is very important in these. The beads are detected in a flow-based, dual color flow-based detection instrument like a Luminex 200 or a Luminex 100, whichever you have in the lab. And basically you have two signals, that is the red laser classifies the bead, whether that bead is suppose HLA-A1 or HLA-A2, depending upon what is there in that bead. And you have a green signal which will tell you the intensity of the fluorescence, that is the phycoerythrin sap, how much intensity it is giving, which will render it positive or negative. So suppose you have an A1 bead, that will the red signal is going to tell you, red laser is going to tell you that is the A1 bead, and whether that A1 is positive or not positive will be with the green laser. So this is basic about the Luminex instrument, and now we have tests that can be done on this Luminex-based platform. You have to have a Luminex platform in your lab to start these tests, and any advanced lab nowadays, whether it's immunology lab or the lab which is trying to just start, you have a Luminex platform. So PRA or antibody screen is what a basic test that we can all do with. It is a test that I heavily rely on. And what is PRA? It basically measures the percentage of HLA antigens in the recipient antibodies against a panel of antigens. So suppose you have 40 panel of antigens from the donors that are there, and how many of them that will come positive will determine the PRA. So PRA it can be both quantitative or qualitative. So when it is quantitative, it is called as ID and PRA ID, and when it is qualitative, we call it as an HLA antibody screening. So what it does is it indicates the sensitization level in the transplant candidate, so you can know how much your candidate is sensitized. You can know the specificity to some extent what it is. Higher the PRA means higher immunological risk, and you can assess the sensitization by the presence of pre-existing HLA antibodies. So they are two types, like I said. Quantitative PRA, you basically measure the strength and the percentage of HLA antibodies, so it is expressed as a percentage. And so this will give you the amount of immunization or the risk stratification you can do with the PRA screening. It is more precise and used in the risk stratification, whereas qualitative antibody screen gives you the presence or absence of antibodies. That means you will know whether the antibody is detected or not detected. It is just a positive negative response. But this is also very handy because if there are antibodies present, you can always go and determine whether they are donor specific or non-donor specific. Whereas if they are absent, it means there are no antibodies, and therefore the likelihood of having a donor specific antibody is almost negligible. So it gives this positive or negative information, but still it is used in the basic screening of the test. So interpreting of PRA, obviously it is expressed as a percentage. You can stratify it. So low PRA means less than 20%. That means 20% of the panel is positive. Moderate is around 20 to 80%, and greater than 80% means high PRA, and therefore the patient is highly sensitized and requires high and advanced desensitization protocols. So this is how a PRA or a screening result looks like if you see. So there are 7 beads in the class 1 and 5, basically a blend of disease and blend of beads, and so class 2 there are 5 beads. So you can see the raw value on the top in the green. That means that this is less than 1000. That is the MFI values that is being depicted. So once the MFI values, you can have a cutoff level for them, and if it is less than 1000, obviously we presume it is negative. So in this case, it is a negative report. On the second part, you can see we have run the positive control, and all the beads, like the 7 beads in the class 1 and the 5 in the class 2, are all positive. They are more than 1000. In fact, they are almost to the tune of 15,000. So this is a positive HLA class 1 and class 2, and this will give you whether, so this will just tell you that the class 1 or class 2 is absent or present for antibodies. On the contrary, you have a PRA ID, that is the quantitative ID, where you can see the top panel. You can see that it is positive, where the MFI levels is greater than 1000, and these are generally the DQ antibodies. On the right, you can see they are mostly the DQ antibodies. Some amount of specificity can be determined. Whereas if you see the lower part, which is in green, is negative, and that are the antibodies which are absent. So you have a fair idea of that. It is a ID, and you know these kind of antibodies are present. It also gives you a percentage. You can see on the right hand column, it is showing that 93% or 90% of this is PRA is positive. So Luminex crossmatch is the second test that we can do on these bead-based assay. We have had a session on this. Basically, it is a crossmatch. So you require a donor cell and patient serum. Donor cell, how do you get it? Through a lysate. So it's a lysate-based crossmatch. So you have to have to make a lysate, you add a detergent, and the HLA that comes out, it's captured by the captured antibody here, and then you add the serum from the patient, which will have the antibodies. So if there is an antibodies that is present, it will be it will have a sandwich here, and you can detect it with the secondary antibody, which is fluorescently labeled. So basic principle is donor cells and patient serum is what you react with, and it is a lysate method. So we have been talking about lysate method in the morning, that what are the problems associated with it. Yes, there are. But then once you take it into an algorithm, and you want, if you interpret it right in light of other tests, I think it's a very useful test, more so because it is very economical. And yes, it has been labeled as a DSA test, but it's actually a Luminex based crossmatch. So this is how the sheet will look like. If you see, to make it more sensitive, we have a lysate control reagent that we add to, this will actually tell you that your lysate test is functioning properly. It's like a quality check. So this should be there, and then these are the test samples that we run. So you can have your own arbitrary cutoff values, but we keep it at 1000. So MFI of 1000 is what we keep as a cutoff here. And these are the adjustment values to actually adjust to the background that may occur. And for these, we have these 3 beads, which will give you a background value. So there are multiple quality checks that have been put in the Luminex crossmatch to denote whether this test is actually positive or negative. And you can see there is a positive control and there is a lysate control as well. So once that happens, this is how the result will look like. On the first case, you can see that the raw value is around 5400 for class 1 and 4,400 for class 2. So that means it is greater than 1,000 and the adjusted values are all above 4,000. So this looks like a positive test for HLA class 1 and class 2 antibodies. Similarly, on the second, you can see that it is less than 1,000, so it looks like a class 1 and class 2 negative for the sample that is in the green. So this was the paper that we actually published, and we did around 750 odd samples for Luminex crossmatch, and we could do around 350 tests for CTC crossmatch, Luminex crossmatch, and HLA antibody screen, and we compared all the three, and we found out that Luminex crossmatch is a test that is very useful. It is good in the sense that it has got high sensitivity to detect donor-specific antibody. It does not require viable cells. It is a very rapid test. The results may come in 3 to 4 hours. Whereas if you start doing single antigen, obviously you have to have antibody profile of the patient, and then you have to do donor HLA typing as well. So the cost is another factor for getting the DSA done. And you can store the lysate for a year or so. So basically, if you have a cadaver and you have a donor lysate that is available, you can retest, or for that matter, even for research purposes, you can store the lysate for the donor cells. The bad is that it gives some false positive. We all know that. We were discussing that in the morning as well. Luminex crossmatch gives false positive, especially in the class 2. That is what we came across in our study also. There were 4 to 5 cases in those patients in which single antigen bead was negative and donor Luminex crossmatch was positive for class 2. So it requires additional confirmation with SAB assay. Obviously, no one test is the answer. You have to have multiple tests or an algorithm in place to actually go ahead and predict the transplant outcome. And it does not detect DQ and DP antibodies. So this is another problem. Nowadays we are coming across a lot of DQ antibodies, and these DQ antibodies are of course clinically significant, and you need to determine them. So this Luminex crossmatch is not going to mostly detect these DQ antibodies. And so therefore it cannot be used as a standalone test. It must be correlated with other tests, but it still finds a way in our country where it's cost constrained, and if you don't have a flow crossmatch in place. So you have one equipment which can do screen, which can do Luminex crossmatch, and that is Luminex. So if you have just the Luminex, you can start with the Luminex crossmatch as well. Virtual crossmatch is nothing but you are trying to detect the single antigen bead assay antibody status in the patient, and you are trying to compare it virtually with the donor HLA typing to determine the donor specific antibody. So basically it's like a virtual crossmatch. It is similar to what we do as a electronic crossmatch in the red cell serology or in transfusion medicine. So if there is a donor specific antibody, you know the specificity of that antibody, and you can actually monitor that antibody, go for desensitization, and then transplant the patient. So yes, single antigen bead assay is very sensitive and very specific. It is a solid phase Luminex based technique. It will give you the specificity of the antibody, and it will provide precise profile, and that can be monitored both pre-transplant and post-transplant. So this is how the Luminex single antigen bead assay will look like. You can stratify as well. The ones on the left are with the high titer MFI or MFI, which is more. So you can know that red and the orange is the positive ones, and the ones which are yellow and the blue are having relatively lesser MFI. And this is how it looks like as a sheet. You can see that the patient prospective donor typing has DQ beta 1 O3O3, and that same DQ beta 1 O3O3 is present at the antigen ID 256, and it has got an MFI of 11,000. So this gives you a virtual crossmatch that is positive. Once that is positive, obviously you know which one is positive. You can actually monitor that, or you can change the donor if you are lucky and you have more donors. So your donor specific antibody, once you know the specificity, you can always, if you are lucky and you have more donors, you can actually do the donor typing and choose which donor you want to actually go for as a prospective transplant. So all said and done, we could understand that, okay, single antigen bead assay is very sensitive, very specific. Of course, it's an expensive test, but also